السلام عليكم ورحمة الله وبركاته.
السلام ورحمة الله وبركاته. أهلا.
ازي حضرتك يا دكتور؟
الحمد لله رب العالمين. إن شاء الله كلكم تكونوا بخير وكويسين.
الحمد لله كله تمام.
السلام عليكم، ازي حضراتكم؟
الحمد لله.
احنا جاهزين نبدأ ان شاء الله يا دكتور.
أيوة بس الناس مش جاهزة.
انا بفكرهم على الواتس وعلى الفيسبوك ان شاء الله يدخلوا.
هنبدأ إن شاء الله. بسم الله الرحمن الرحيم. Today we are going to complete our lectures about fluid and electrolyte disturbances in the newborn baby and how you manage them. And today's part is the most important part because it will deal with the treatment and management. Before we start, I have some comments. I've read in your comments that you don't like us to speak in English. You want us to talk in Arabic, which is okay for me. I think I know Arabic more than all of you, but this is not the issue. The issue is that you have to attend lectures in English and هتكلم بالعربي شوية. انتوا درستوا في كلية الطب بأنه لغة، عربي ولا إنجليزي؟ بعدين الامتحانات اللي عديتوا عليها كلها كانت عربي بالعربي ولا بالإنجليزي؟ بعدين انتوا بتدرسوا إنجليزي من الحضانة في مصر، والناس اللي متخرجين من كلية الطب دولت كريمة الكريمة، يعني المفروض يكونوا أشطر ناس في كل حاجة including بما فيه اللغة الإنجليزية. الإنجليزي ده راح فين؟ وبعدين أنت لما بتقرأ كتاب أو بتقرأ جورنال، بتقرأ مقالة في جورنال أو في أي حاجة، بتقراها بالعربي ولا بالإنجليزي؟ وبعدين الناس اللي فيكم اللي هم في أكاديميا اللي بيحضروا رسالات ماجستير ودكتوراه بيحضروها بالعربي ولا بالإنجليزي؟ والمناقشة بتاعت الرسائل بتاعتهم دي هتبقى بالعربي ولا بالإنجليزي؟ وبعدين اللي فيكم هيبقوا أساتذة إن شاء الله بيكملوا في الأكاديميا ويحضروا مؤتمرات جوه وبره مصر. المؤتمرات دي بتبقى بالعربي ولا بالإنجليزي؟ أنا مش عارف المشكلة عندي ولا عندكم. مش عيب إن الواحد يبقى عنده مشكلة في حاجة ويحاول يصلحها، وكحل وسط اتكلموا معايا بالعربي، جاوبوا الأسئلة بالعربي، اسألوا بالعربي. وأنا هحاول أتكلم بالفرنك وأراب زي ما أنتوا عايزين، بس دي الطريقة دي it hurts my ears. ما بعرفش، ما ببقاش مرتاح فيها. يعني نتكلم عربي كله من الأول للآخر، يا ما نتكلم إنجليزي من الأول للآخر. ف اتكلموا معايا بالعربي، حاولوا تتعلموا إنجليزي كويس، ومش عيب يعني إن أنت تتكلم بالإنجليزي. ده مش معناه إن أنت ما بتحبش لغتك العربية ولا إن أنت مش شاطر فيها، ولو إن أنا أشك إن اللي هيبقى مش شاطر في الإنجليزي هيكون شاطر في العربي كمان، ويمكن في الطب كله يعني. المهم ده كان أول كومنت ليا. تاني تعليق ليا بالنسبة للسادة الزملاء اللي بيحضروا مواضيع، النواب اللي بيحضروا المواضيع اللي احنا بنوسعها عليهم. لما تيجي تحضر موضوع يا ابني، انت المفروض تبص للموضوع بزاوية من طريقتين. الطريقة الأولانية اللي هي طريقة نظرة شاملة بانوراميك فيو. يعني ايه؟ يعني الموضوع ايه الاجزاء بتاعته، ايه العناوين اللي هتتكلم فيها، وبعدين بعد كده تتكلم بعمق in depth، تتكلم بعمق في كل عنوان له أهمية، له علاقة بالموضوع بتاعنا، عشان من غير ما نفهمه مش هنفهم بقية الموضوع. من غير ما تعرف امبريولوجي مش هتعرف باثولوجي وسيرجيكال انترفنشن. من غير ما نعرف فيسيولوجي مش هتعرف باثولوجي، وبالتالي تريتمنت اند بريفنشن اند دايجنوز. هي الامور لازم تيجي كده، وعلشان كده انت بتدرس في الكليه سنتين بيزك ساينس، مش عشان رفاهيه، لا، عشان انت ده بتفرش فرش يخليك قادر بعد ما تدرس البيزك ساينس دي ان انت تفهم بعد كده علوم الباثولوجي، وبعد كده تخش على الكلينيكال واللابوراتوري. فمن فضلكم يا اما تحضروا بالطريقه دي يا اما بلاش تحضروا خالص، ما تتعبوش نفسكم يعني. آه، اعتقد اتمنى ان الرساله دي توصلكم. هنكمل بقى العلاج. اول موضوع هنتكلم فيه ديهايدريشن، الجفاف. الديهايدريشن قلنا ان قسمناه لمايلد مودريت وسيفير. الدرجة البسيطة أقل درجة من 3 ل 5% loss of body weight، وبعدين اللي في النص من 5 ل 10، وبعد كده اللي أكتر من كده بيبقى severe. and the baby will be in shock، هيكون في صدمة، حالة صدمة. العلاج في معظم حالات الديهيدريشن، طبعا احنا قسمنا الديهيدريشن لأنواع حسب تركيز الصوديوم، هايبوناتريميك وهايبرناتريميك وايزوناتريميك. لكن في معظم الحالات حتى لو انت مش متأكد اذا كان نوع الديهيدريشن ايه، فبتدي تعمل حاجة اسمها فلويد ريسسيتيشن، الانعاش بالسوائل. الانعاش بالسوائل بتدي محلول ملح، بتبدأ بدوز من 10 ل 20 ملي لتر لكل كيلو جرام صوديوم نورمال سالين اللي هو 0.9 صوديوم كلورايد. بتديها في خلال من 10 ل 20 دقيقة، وممكن تكرر الجرعة دي لو محتاج لها. خلاص، دي الطريقة البسيطة خالص. الطريقة الأصعب بقى إن أنت طبعا لازم تعرف قد إيه الكمية المفقود من الوزن، وبعدين قد إيه مفقود من الوزن ده في صورة سوائل والكترولايتس. خلاص، فبتعمل ايه؟ بتطرح الوزن الحالي من الوزن الايه الايديال. وفي اول ايام زي ما قلنا بنستعمل ذا بيرث ويت اللي بنسميه دراي ويت او بيرث ويت، مع ملاحظة ان نورمال بيبي لو هو تيرم بيفقد من 5 ل 10% من البودي ويت في الايام الاولى، وده فيسيولوجيك. عند اليوم العاشر بيبقى يرجع تاني للبيرث ويت بتاعه. خد بالك من الملحوظه دي عشان ما تديش فلويدز او الكترولايتس زياده. لو هو بريتيرم بتوصل من 10 ل 20% لوس، فيسيولوجيك لوس في الفيرست فيو دايز اوف لايف، ودي بتبقى معظمها ووتر بالرغم من ان في دايوريسيس اند ناتريوريسيس، لكن اللوس فقدان الميه اكتر من فقدان الصوديوم. طيب نيجي لحاجه تانية، فلويد اوفرلود. وقلنا خد بالك فلويد اوفرلود ما هوش شيء حميد، ما هوش شيء حميد على الاطلاق، خصوصا في الاطفال اللي هي مولوده بدري. ان ده وكل ما كان الاماتيوريتي اكتر والستيشنال ايج اقل، كل ما كان البيبي ده متعرض لفلويد اوفرلود. اللي بيحصل ايه؟ ان احنا قلنا في فيسيولوجيك ويت لوس من 5 ل 10% في الطفل اللي نازل في ميعاده، ومن 10 ل 20% في الطفل المولود بدري. ف you should allow for this weight loss. لكن لو انت حاولت تدي فلويدز وتمنع هذا الفسيولوجيك فلويد لوس، هتخلي البيبي يخش في فلويد اوفرلود which has uh, 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 bad effect on the morbidity and mortality. مثلا it can make the patent ductus open more and does not close physiologic، أو هتخلي recovery from BPD or even the development of BPD يحصل أكتر. أو لو أنت بقى بتدي فلويدز وبتحسب زيادة، يعني أنت بتدي TPN مثلا وعمال تدي فلويدز زيادة ملهاش لازمة، او البيبي كان في حاله ديهيدريشن وانت اوفر استيميتد ده ويت لوس. كل دي حاجات بتؤدي إلى الفلويد overload which is serious especially in the preterm babies. ونتيجة الفلويد overload ده بيحصل accumulation of fluid in the interstitial space ويعمل edema. Edema will affect the different organs of the body. It will interfere with the function of every and each organ. اوكي؟ طيب تعالجها ازاي؟ اول حاجه فلويد ريستريكشن، يعني تقلل كميه السوائل اللي سيادتك بتديها للبيبي. بدل ما هو مثلا انت المفروض لو ما كانش عنده اوفرلود بتديله 100 سي سي او 100 مللتر اوف بير كي جي بير داي اوف فلويدز، خليهم 80. وبعدين تاني حاجه بتدي دايوريتكس. استخدام مدرات البول في الأطفال مهم جدا، ولازم كل نيوناتولوجيست وبيدياتريشن يعرف بالظبط، ويعرف امتى يستعمل أولا إيه أنواع الدايوريتكس دي، وامتى يستعمل ده وما يستعملش ده، ولما يستعمل واحد فيهم يستعمله إزاي، وإيه السايد إفكتس المشاكل اللي ممكن تنجم عنه، وإيه الكومبليكيشنز اللي ممكن يسببها للبيبي. ما تستعملش دواء ما انتش عارفه كويس، وما تبقاش مبسوط قوي انك بتعرف تستعمل من 20 30 دواء، في حين ان انت لو عرفت 3 4 ادويه كويس جدا. وكويس جدا يعني ايه؟ يعني ميكانيزم اوف اكشن، فارماكو داينامكس، فارماكو all the pharmacology, the metabolism, the absorption, the secretion, the half-life, when starts to kick in the body، امتى يبدأ يشتغل، ويشتغل لقد كام ساعة، وبعد كده امتى مفعوله يروح، وامتى تستعمله في الحالات العادية وامتى تستعمله في الحالات المرضية pathological condition. Okay, so it is critical that NICU clinicians understand mechanisms of actions, potency, routes of administration, side effects for the different classes of diuretics. أهم نوع بنستعمله very common, very efficient, very potent، the loop diuretics. زي ايه؟ example اللي هو ليزكس. So بيعملوا ايه loop diuretics؟ بيشتغلوا على loop of Henle. They induce sodium clearing by inhibiting the reabsorption of sodium through the sodium potassium chloride channels اللي هم اسمهم Na1K1 2Cl اللي موجودين على luminal side of the thick ascending loop of Henle. ده الميكانيزم اوف اكشن وده السايت اوف اكشن. اهم مثل له ليزكس، وفي واحد تاني very very potent and side effects اقل من الليزكس اسمه وميتانايد. I don't know if you use it in Egypt or if it's available in Shotby. I have no clue. خلاص. ميزة البوميتانايد ده it's very powerful. It's about 40 fold 40 مرة أقوى من الليزكس، والسايد افكتس بتاعته أقل من الليزكس. خلاص. عيب الليزكس بقى إنه بيعمل أوتوتوكسيسيتي especially in the preterm babies لما الجرعة تزيد عن 50 مللي جرام. بوميتانايد احسن في الحاله دي للاطفال اللي هم عندهم عرضه اكتر ان هم يجي لهم الاوتوتوكسيسيتي دي. غير كمان ان هو فيري فيري بوتنت، بس تاخد بالك لما تستعمله عشان ما تعملش سيفير ماسيف دايوريسيس وتدخل البيبي بتاعك في ديهايدريشن تاني، بدل ما كان في اوفرلود يخش في ديهايدريشن. تاني نوع اسمه ثايرويد دايوريتكس، دول اضعف شويه، ودولت they inhibit sodium 1 chloride apical contrasporter referred to as the thiazide sensitive sodium chloride co-transporter. This is the mechanism of action. خلاص. الاثنين المشهورين اللي هو كلوروثيازايد وهيدروكلوروثيازايد. بعد كده في نوع ثالث اسمه بوتاسيوم سبيرنج دايوريتكس. لما بتستعمل الدايوريتكس كتير في الأطفال، بالذات في الأطفال البريتيرم، بالذات في حالات بي بي دي، بيخشوا في حاجة في الكترولايت ديستربنس، بيخشوا في هايبوكاليميا وحاجات تانية زي الكونتراكشن الكالوسيس. ففي الحالة دي يا إما تستعمل لوب دايوريتكس بطريقة معينة هنقول عليها، يا إما تستعمل other diuretics اللي هم thiazides. بالنسبة لللوب دايوريتكس اللي احنا بنستعملهم كتير قوي، بعد شوية بيبقوا ريفراكتوري. الجسم بيبقى الكدنيز becomes refractory، خلاص ما بيشتغلوش او الايفكت بتاعهم يقل. فبتعمل ايه؟ بدل ما انت بتدي 1 مللي جرام بير كي جي بير داي، فبتدي 2 مللي جرام بير كي جي per day, but not every day. You give it every other day. And you divide it into 2 doses. You give it every 12 hours. يعني بدل ما كان بياخد ليزك سبت وحد واثنين وثلاث واربع وخميس، لا، انت هتديه سبت واثنين واربع وجمعه وهكذا. هتعمل ايه؟ بدل ما بتدي 1 مللي جرام بير كي جي في يوم السبت والحد والاثنين والثلاث بير داي، لا، هتيجي يوم السبت هتدي 2 مللي جرام بير كي جي بير داي، وهتديهم على مرتين، مره الصبح ومره بالليل، تقسم الجرعه مرتين. او تبدا تدي other diuretics او to add them. يعني you can add the thiazides to the loop diuretics. يبداوا يعملوا electrolyte disturbances، بالذات البوتاسيوم loss، بتدي لوب potassium sparing diuretics، ودولت they don't cause loss of potassium in urine. واهم اكزامبل لهم اللي هو الالدكتون او سبايرونولاكتون، which inhibits aldosterone secretion by competitively binding the mineralocorticoid receptors in the kidney. This is a very, very brief idea about diuretics. You should know much more than that. لكن عشان وقت الحضرة ما يستحملش ان احنا نتكلم بالتفصيل في كل حاجة، مش هنقدر نغطي كل حاجة. بعدين في ويك diuretics carbonic anhydrase inhibitors اللي هو acetazolamide or diamox. وده ويك قوي، لكن له استعمالاته. ساعات ناس كانوا بيستعملوا في الهيدروسيفالس، او زي ما هنشوف بعد كده لو في edema in heart failure, carbonic anhydrase is more helpful. It's more helpful other than the other diuretics. المشكلة اللي بعد كده hyponatremia. واحنا قلنا hyponatremia يعني صوديوم اقل من 135. هو المفروض 130، بس ناس بتستعمل 135 عشان ايه؟ تبقى مور كوشس، ما تدخلش البيبي بتاعك في هايبوناتريميا. فلما تعلي الليفل شويه بتاع الهايبوناتريميا هتبقى ايه؟ مش هتدخل البيبي في هايبوناتريميا. وبعدين المانجمنت بتاعها بيعتمد على حاجات كتير. اولا هاو لو از ذا صوديوم. تاني حاجه هل في سيمتومز ولا لا. اهم سيمتوم اللي هي سيجرز كونفالجنز، اللي هي كونفالجنز. فلو عندك بيشنت السيرم صوديوم بتاعه اقل من 120 ملي كويل بير لتر، وعن without seizures في الحالة دي بتدي بدل ما بنستعمل في كل الحالات النورمال سالين اللي هو 0.9 بتدي 3% very concentrated. Instead of 0.9 you give 3% sodium chloride. بتدي 1 مللتر per kg over 4 to 6 hours. وما تديهوش بسرعة وهنشوف ليه. ولو صلحت هايبوناتريميا بسرعة it's very serious. هنشوف ليه. خلاص؟ وبعدين then you can repeat. The goal is to keep the level above 120 and then to go slowly to the physiologic range, but don't correct more than 12 milli equivalent per liter per day. أو ما تديش أكتر من 0.5 milli equivalent per liter per hour. لما بتعمل rapid correction بيحصل حاجة اسمها brain stem injury, و this is very serious لأنه بيحصل rapid dehydration للبرين ستيم. بيحصل central pontine demyelination. Central pontine demyelination. This is something serious, and it will cause severe damage and kill the baby because it will affect the brain stem, which has all the important centers in the brain. اوكي طيب لو انت عندك patient وعنده بقى CNS بغض النظر عن الليفل اوف صوديوم عنده سيجرز، في الحالة دي لازم تبقى مور اجريسيف شوية. برضه هتستعمل 3% صوديوم كلورايد، تستعمل 2 مللتر بير كي جي over 10 to 15 minutes. المرة اللي فاتت كنا بنستعمل over 4 hours، لكن المرة دي هنستعمله over minutes 10 to 15 minutes لغاية till the baby stops seizing. وبعد كده هنكمل بنفس الطريقة، وبرضه البريكوشنز بتاعتنا ما نزودش عن 12 ملي ايكويفالنت بير داي بير لتر بير داي. لو انت بقى الهايبوناتريميا دي سببها هايبرفوليميا، وذا بيست اكزامبل از سياد اتش. سياد اتش ده inappropriate secretion of anti-diuretic hormone سياد اتش. في الحالة دي أهم حاجة إنك تعمل fluid restriction. fluid restriction خلاص. أهم حاجة تقلل fluids، تبدأ ب 20 مللتر per kg per day and you can go more. مجرد ما هتقلل الفلويدز هتقلل الهايبرفوليميا، هتقلل هايبوناتريميا، وبالتالي السيمتومز هتقل، برين إديما هتقل، والتيشو والانترستيشيال accumulation of fluid هتقل. واتكلمنا على central pontine demyelination. This is extremely important. خد بالك من القصة دي، ما تصلحش هايبوناتريميا بسرعة جدا إلا لو البيشنت is seizing، وفي الحالة دي برضه still have limits. لو انت بقى عندك هايبوفوليميا هايبوناتريميا يعني there is loss of both sodium and water، وفي الحالة دي this baby is dehydrated، فهتديله normal saline bolus. خلاص؟ اعرف ازاي البيبي عنده هايبوفوليميك هايبوناتريميا؟ طبعا السيرم صوديوم هيبقى قليل، يورين اوتبوت هيبقى قليل، بودي ويت هيبقى لوست، زي ما اتكلمنا في المونيتورنج اند اسسمنت. في بقى ناس بتعقد الامور وبتحسب الصوديوم ديفيسيت وبعدين تصلح صوديوم ديفيسيت برضو باي ايكويشنز. هي موجوده عندكم، هبعتها لكم. لو if you are more interested you can go this way. يعني عشان تحسب صوديوم ديفيسيت بتقول ان التارجت بتاعك صوديوم يبقى 135 minus current sodium level times 0.6 which is the distribution width of sodium in the body. هتطلع مثلا ان البيبي عنده 10 من الايكويفالنت ديفيسيت، بتقسمها بحيث ان انت تدي صوديوم كلورايد تعمل half correction in the first 8 hours وبعد كده تصلح في بقيه الوقت لغايه لما توصل ل 135. دي طريقه ودي طريقه والاثنين صح. الطريقه الاولانيه اسهل. هايبرناتريميا يعني صوديوم اكتر من 150. طبعا the most common cause of hypernatremia is dehydration. واخدين بالكم؟ وفي الحاله دي بيبقى في loss of free water more than sodium. خلاص؟ فالحاله دي ان انت بتدي ايه؟ في طرق كتير. اولا if the baby is really dehydrated هتدي صوديوم كلورايد 0.9 صوديوم كلورايد نورمال سليم 10 to 20 ملليلتر زي ما في حاله اي ديهيدريشن او شوك. حاجه الثانيه ممكن تدي free water and this free water could be given even orally. ماشي. if the baby is on IV fluids or on TPN هتقلل الصوديوم، ممكن تدي just دي 10W بس، او TPN بدل ما بتدي 5 من الايكويفالنت بير كي جي بير داي في التي بي ان خليها 3 خليها 2. اخد بالك؟ this is how to treat hypernatremia. نيجي للهايبوكاليميا. هايبوكاليميا اتكلمنا عن اسبابها كتيره and طبعا you must read the cause and you have to give potassium replacement in the form of potassium chloride. And this table shows you the different doses that you can use at different situations. مش هنوجع دماغكم بالارقام. Hyperkalemia which is more serious than hypokalemia. وقلنا in the preterm baby in the first few days of life 24 to 72 hours is 25% of them will have hyperkalemia depending on how is the gestational age. The preterm baby لو سبته كده لحاله he is more liable to hyponatremia and hyperkalemia initially. I mean initially after the phase of diuresis for the sodium and early for the potassium. Hyperkalemia is serious. It can cause cardiac arrhythmia, can cause can cause sudden death. علاج الهايبركاليميا طبعا بتعمل ايه؟ بتدي حاجات كتيرة قوي، من ضمنها كالسيوم، من ضمنها صوديوم بايكارب، من ضمنها انسولين اند دي 10W، من ضمنها البيترول انهاليشن. And if all fail you do diuresis, you do غسيل you do dialysis, you do غسيل كلية. Metabolic acidosis, which is very common. All the preterm babies, especially like 24, 25, 23 weeks, and after the first few days of life will have a state of metabolic acidosis. And you have to deal with the cause if there is a pathologic cause. But if it's only prematurity or if it's acute issues like HIE, you have to give bicarb. I know there is a lot of debate about bicarb in the newborn babies, but in many situations you have to give sodium bicarb. And there is a magic trick I told you before several times. When you have a preterm baby, just preterm, and on day of 3 or 4 has metabolic acidosis, you can give bicarb in the form of 0.5 milliequivalent per kg per hour for 12 to 24 hours or till the acidosis corrects. This is a very magic trick and it never fails. You can use it in your NICU and you'll find that it's very helpful. But you should know which babies are good candidates for the use of this trick. بتعمل ايه بقى؟ في طرق كتير عشان تحارب الميتابوليك اسيدوزس غير ان انت تعالج الاندرلاين كوز. And if the baby is on the ventilator, you can hyperventilate your baby, and then you can give sodium bicarb, as I told you how you use it in the preterm, or generally you do calculate the bicarb deficit, and then you correct this bicarb deficit, the same as we did with in the sodium. To know the bicarb deficit, there is an equation, which is the base excess times body weight times 0.3. And then once you know, you need to know the measured bicarb. This is the measured bicarb. Base excess times body weight times 0.3. And then the target bicarb minus this one, this measured bicarb, times 0.3. This will give you the amount of bicarb that you should give. You correct half in the first 8 hours and then half, the other half over the rest of the day. In 24 hours to correct acidosis. Certain conditions like renal tubular acidosis, proximal and distal, they have specific treatment. The goal is to go back of the pH to 7.2. 7.2. Metabolic alkalosis, and I don't know if you give me a very good example of metabolic alkalosis. What is a good example? One of them is common, one of them is rare. Two causes of metabolic alkalosis. Can you give me 2 examples? Metabolic alkalosis. Did you attend my lectures before the first part and the second part? Let us see. English better? Oh, no way. No way. أنا مش عارف أرضي مين فيكم ولا مين. دلوقتي بيقول لك English better. English better. I don't know. But I respect this opinion. BPD causes metabolic alkalosis? I don't know. How? Lasix, yes. Contraction alkalosis, we just mentioned that. Necrotizing enterocolitis, it can causes more acidosis. Diuretics, pyloric, yes. Congenital hypertrophic pyloric stenosis. What is the metabolic derangement in the pyloric stenosis? What do you have in pyloric stenosis? CHPS, congenital hypertrophic, yes. Bartter syndrome, yes. Yes, it is a very good example, although it's rare, yes. So what is the metabolic derangement in congenital hypertrophic pyloric stenosis? Hypokalemic, this is part of the derangement. Hypochloremic, yes. There is hypokalemic, hypochloremic, metabolic alkalosis, and there is dehydration. So the treatment something important also about acidosis. I forgot about that. Sometimes when you have metabolic acidosis and the baby is on TPN, instead of giving sodium chloride, potassium chloride, you give sodium acetate and potassium acetate. And the acetate or lactate turned in the body into bicarb. And this is a very easy and simple way to help in dealing with metabolic acidosis. Sodium and potassium acetate or lactate. Alkalosis. So in these cases, usually there is hypovolemia, there is dehydration, there is depletion. And in this condition, you correct the volume depletion, giving fluids, fluid resuscitation, you correct potassium, you give more potassium, correct chloride depletion, and this is what you do in the congenital hypertrophic pyloric stenosis. Bartter syndrome, treatment of the cause is more important, which is endomethacin or ibuprofen, as we are going to see in the case. And then how you correct volume depletion again using normal saline in the by using fluid resuscitation. And here comes the role of carbonic anhydrase. Another method of treating metabolic alkalosis in an edematous patient, like in congestive heart failure, is to give carbonic anhydrase, which causes mild increase in the production of urine that has high bicarb content. And this will lead to reacidification of the blood. Hyperchloremia. Usually hyperchloremia is part of the metabolic acidosis. So, and then you have to reduce chloride in the fluids. You have to hyperventilate your intubated patient, and you have to treat the acidosis. In proximal renal tubular acidosis, you have to give large quantities of bicarb, vitamin D, potassium. Okay? In the distal renal tubular acidosis, you have to give long-term alkali. It's either PO or IV. And we talked about the potassium and chloride. Hypochloremia, usually associated with metabolic alkalosis, and we discussed that. You have to correct the dehydration. You have to correct the chloride deficit, the potassium deficit, and then you try to acidify, give more acids. Like if you give in TPN, you give sodium chloride, potassium chloride instead of the acetate or lactate. And we talked about this. Of course, there is details about management of congenital hypertrophic pyloric stenosis, but the goal is to make the anesthesiologist happy by giving a bicarb level of 30, serum chloride of at least 100. Condition requiring fluid restriction, we have many conditions like that, like the BPD, the patent ductus, HIE, in the AKI and renal failure, in SIAD-H, conditions requiring increasing fluids, like in diabetes insipidus, because there is dehydration and loss of water, in the abdominal wall defects, because there is loss of fluids and electrolytes from the exposed gut, the same in ichthyosis, and in GI suctioning, in the hydrocephalus drainage, and other conditions. In hypovolemic shock, of course, the treatment is fluid resuscitation. And I usually say this statement: don't wait for hypotension in dehydration or in shock. It is a very late sign. But if there is tachycardia, decreased urine output, this is a good indication. Of course, the capillary refill is a very good sensitive measurement. And the fluid resuscitation is sodium chloride, normal saline 0.9, 10 to 20 milliliter over 10 to 20 minutes, and then you still can repeat. We are done. Conclusions, the homegoing lessons. Every medical provider taking care of newborn babies, term and preterm, should be aware of the fluid and electrolyte homeostasis disorders and management. During delivery of the baby, extracellular, there is immediate changes following delivery. And the most important of them is the change in the fluid compartment and the physiologic diuresis, and the body weight drops, the body fluids drops, the compartment changes, as we mentioned in details. And the baby will adapt, and you have to follow and allow adaptation in fluid and electrolytes. Otherwise, if you try to antagonize this, you will have the baby go into fluid overload. And we talked about the early stages, which divided into 3 phases. And every phase has its own fluid and electrolyte requirements, as mentioned in the second part of the lecture. And of course, some environmental changes can affect fluids and electrolytes, like the radiant warmer, the phototherapy, and other problems. That's why fluid and electrolyte homeostasis is extremely important. And we have to take care of that. And to be aware of the pathological conditions affecting this homeostasis, and how to deal with the different situations with different problems, how you can manage them. And before you start managing, you have to do clinical assessment and how to monitor your baby. Now before we start answering the MCQs, do you have any questions, any concerns, any comments? Because I need to finish the MCQs rapidly. I will not go into the details because the details are already mentioned in the lectures. And then I will give you some cases where the babies have fluid and electrolyte disturbances. Any comment, any question? Okay, start the MCQs again. We did this before the lectures, and now we are doing them after the lectures. A 6-hour-old preterm neonate, birth weight is 640 grams. Stational age is about 24 weeks. Observed under a radiant warmer. Ambient humidity is 80%. The infant requires mechanical ventilation. FiO2 is 0.42, and there is an NG tube. No anomalies or syndromic features, and you are estimating the total fluid and electrolytes. Question: of the following, the major consideration in fluid electrolyte management for this infant is gastric drainage, water loss, insensible water loss, stool water loss, sweat water loss, urinary water loss. All of them are important. Maybe the sweat is not included, but the other 4 are extremely important. But which one is the major? Which one is the major? So B, 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 B. No, I'm sorry. All these answers are incorrect. It is not B. I'm not minimizing or underestimating the insensible water loss. But we had a table. We had a table that showed you the fluid requirements, fluid losses, and how you estimate. Still, the role of the kidney is more important than the insensible water loss. Okay? Sensible water loss is extremely important, but it comes number two. Number one is the kidney and the changes in the urine output and the diuresis comes number one. Okay? And then comes the insensible water loss, which you cannot calculate. You have to go to the tables. Question number two. A preterm unit typically loses 10 to 20% of body water during the first week after birth. This weight is considered physiologic. Of the following, the physiologic weight loss in the preterm unit is best attributed to a postnatal decrease in what goes down: the body fat, the caloric intake, interstitial fluid volume, intracellular fluid, the plasma volume. C, interstitial, C, yes. Yes, this is correct. It is the interstitial fluid. Some 25 to 50% of neonates who weigh less than 1,000 grams at birth or whose gestational age is less than 28 weeks develop hyperkalemia in the first 24 to 72 hours after birth. Of the following, the most likely cause of hyperkalemia in such preterm neonate is high exogenous potassium. You give them a lot of potassium. High proximal tubular reabsorption of potassium. The kidney absorbs potassium at a high rate. Low distal tubular excretion of potassium. Potassium excretion by the kidney is low. Low glomerular filtration of potassium. Shift of potassium from intracellular to extracellular fluid. E, shift, C. I have only two answers. E, C, E, C, E. So it's 50-50. The correct answer is E, shift of potassium from intracellular to extracellular fluid. 4, an infant born at 24 weeks gestation with a birth weight of 600 grams is now 3 weeks old. 3 weeks old, 24 weaker, 600 grammer at birth, and the birth weight and the weight now is at 3 weeks is 640 grams, gained in 3 weeks after the initial loss, and now up 40 grams above birth weight. He is receiving CPAP, enteral feeds by gavage using donor human milk fortified with human milk fortifier and liquid protein of 26 kilocal per ounce, and the total caloric intake is 130 kilocal per kg per day. His growth velocity is 9. Is this normal, high, low? 9 gram per kg at 3 weeks of age. Is this appropriate, inappropriate? And if inappropriate, is it high or low? Low, 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 low. Yes, it is low. A blood chemistry Panel is obtained, and the results are as follows. Sodium is 125. Definitely, this is low. Potassium is 3.2, borderline low norm. Chloride 100, borderline normal low. Bicarb 22, blood urea nitrogen 12, creatinine 0.6, calcium 9, phosphorus 4, total protein 6, and I think albumin was 3. Albumin was 3. I don't know how to get rid of this, but I think albumin was 3. It was low. So the cause of the slow growth velocity in this infant is decreased aldosterone concentration, free water loss, inhibition of sodium, potassium, hydrogen antiporter, and low glomerular filtration rate. What is the cause of this baby low growth? Free water loss, inappropriate low. Oh, yeah. No. What is the answer for the question? Is it A, B, C, or D? A, B, C, or D? No answers. Hala, do you answer this question as C? Late hyponatremia. So the answer is, so what is the answer? If it is hyponatremia, what is the cause of hyponatremia? C, inhibition of, so C. Yeah, this baby is not growing well because of hyponatremia. And the cause of I mentioned before, sodium is a growth factor, especially in preterm babies. Why this sodium is low? Because of inhibition of the sodium hydrogen antiporter. And what does antiporter mean? It is a protein that facilitates back and forth transfer of electrolytes across the cell membrane of all organs. So this is inhibited. The aldosterone concentration is normal, but the response is low. Free water loss occurs early in the first few days of life, and then by day of life, 10 to 15, the baby should regain birth weight. There is no glomerular filtration at this stage. It was initially in the first few days of life. A newborn is delivered at 23 weeks gestation, birth weight 530 grams, umbilical catheters placed, UVC and USE, TPN started, and intralipids initiated. You see how early they started? They started very early. The fluid goal is 130 per kg per day of the following. The statement best describes the rationale for avoidance of early sodium administration. Why we don't give early sodium in the first few days in fluids or in TPM. Usually, we don't give sodium early, like first day of life 1 or 2 or maybe 3. We just give D10W. D10W or start TPN without sodium. And then we have to follow the sodium level because every baby has his own behavior depending on the gestational age and health or clinical conditions. So if you give early sodium, what's going to happen? Administration of sodium will hinder contraction of the neonatal extracellular fluid space. Early sodium administration causes hypernatremia. Neonatal sodium stores are adequate and mirror that of the mother. So what? Sodium resides primarily in the neonatal intracellular fluid space and is not initially required. Is it A, B, C, or D? No answers. You think this is a difficult question? A, Randa. Randa, D. Randa, D. Yahya, Hala, C. So D and C. D and C. C. No, this is not correct. It's not D or C. It is A. I just talked about this and I told you, don't try to interfere with the physiologic changes that occur in the first few days of life, especially for preterm babies. You should allow them to have diuresis. You should allow them to drop their sodium. You should allow them to drop their potassium. And then, because they are liable to hyponatremia, don't wait long. Follow the sodium, and immediately at the time of diuresis, when sodium starts to drop, start giving the sodium. Otherwise, you will hinder contraction of the neonatal extracellular space, which is physiologic. Okay? Early sodium administration causes hypernatremia. This could be correct, but it is not the main reason. Neonatal sodium stores are adequate? No, they are not adequate. Sodium resides in the intracellular? No, it's in extracellular. Potassium is intracellular. The values below are taken from 2 neonates admitted to the intensive care unit. We have baby A, 28 weeker, is now 10 days old. We have baby B, turn 2 days old. And then examination findings and laboratory results for both neonates are shown. Baby A, birth weight 1,200 grams. B was 2,800 grams. This is at day 10. This is at day 2. Current weight, this is birth weight for both. At day 10, baby A is 998. Baby B is 2,600. If this lost more, but the percentage is less. Serum sodium 132, 132 for both at day of life 10 and 2. Urine output is 6 and 4. Is 6 appropriate? Polyuria or oliguria? 4 is appropriate. Still polyuric. Of the following, the best explanation for baby A weight loss when compared with baby B is that weight loss. This baby lost 200, more than 200, and this lost 200, but the percentage is higher here than here. And 200 definitely is more than, I don't know, you can do the math. Of the following, the best explanation for baby A weight loss when compared with baby B is that aldosterone response is diminished. We just answered the question, this A in the previous question. Mineralocorticoid secretion is excessive. Renal secretion is diminished. Vasopressin response is excessive. Which is the correct answer? A, B, C, or D? Randa, A. Hala, A. Yes, the correct answer is A. An 835 grammer neonate to 25 weeks admitted to the intensive care unit, mechanical ventilation for RDS, UVC and UAC placed, heparinized 0.45% sodium acetate. You see, they use sodium acetate. Is infused through the umbilical arterial catheter at a rate of 0.8 milliliter per hour. Parenteral nutrition is inhibited and the total fluid intake goal is 120. Okay. On the second day after birth, 3 milliequivalent per kg per day of sodium is added to the TPN. Trophic feeds started with non-fortified pasteurized human milk. The umbilical arterial catheter is removed on day 5. Changes in the infant's weight, intake and output, and serum sodium values during the first 6 days after birth are shown. So, and this is the days 1, 2, 3, 4, 5, 6. This is the weight change, loss, slight gain, loss. This is the enteral feeds, 0, day 2, 7 milliliter per kg and going up to 30. This is the TPN, 46 cc per kg, going up, and then dropped again. The total IV fluids started with 63 plus the PO, which is 0, and then they started going up, then stabilized. The total FG per milliliter per kg, 120. This is the fluid given, total fluid given. Okay. This TPN plus IV, and then TPN IV PO. So this is the total, 120, 140, 170, 170, 160. And urine output, 55, and then diuresis started, still in diuresis, and then started to drop. Sodium, 141, this is the mother, and then 149 because of diuresis, and then it's dropping because there is more loss of sodium or water than water. There is hypernatremia, and then the baby at this point cannot dilute urine, so sodium will start dropping. And on day 5 was 133, on day 6, 122. Question. A random urine sodium and urine osmolality on the 6th day after birth are. The urine osmolality was 101. Urine sodium was 300. Sorry, and urine sodium 101 milliequivalent. Urine osmolality 391 milliosmol. Of the following, this neonates hyponatremia اللي هي هنا دلوقتي. Hyponatremia could have been best prevented by advancing enteral feeding at a foster space, if they give the PO feeds up and go up faster, fortifying, go up on the calories, increasing parenteral nutrition sodium content on day 5. Yes, they should have given more sodium at this day in the TPN or in the IV. And lowering the total fluid goal after day 3, going down on the total fluids after day 3. Instead of going up, they should have gone down at this day. So why this baby had hyponatremia and how could they prevent it? answers. A, advancing. B or no, I don't see. Yes, A. B, fortifying, going up on calories. Going up on calories will prevent hyponatremia. I don't know. I don't see any relation. Going up faster on the enteral feeds will prevent hyponatremia. D, lowering the total fluid. Why should we lower the total fluid? I didn't teach you that. So you didn't attend. So all answers are incorrect. All your answers are incorrect. I'm sorry for that. Increasing parenteral nutrition sodium content on day 5. If they went up on the sodium in the TPN and IV fluids, sodium would not drop to 133 from 140. Going up on the calories will not help. Going up on the feeds or on the rate of increasing feeds will not help. Going down on the total fluids is not indicated. Why you should do that? This baby needs a lot of fluids and a lot of calories initially, and then the baby will stabilize at 160. I don't know why you answered this question wrong. I have no clue. 8, at 40 weeks gestation at 3,640 grammer, infant born via urgent C-section because of non-reassuring fetal status. Newborn is limp, apneic, Apgars 1, 3, and 6, very low Apgars. Admission to the NICU. Newborn is receiving mechanical ventilation, heart rate 146, blood pressure 52/41, and a mean of 44. Blood pressure is still appropriate. Capillary refill is 4 seconds. You see, the capillary refill is affected first, then comes the heart rate, and late is drop in the blood pressure. Neurologic examination, the baby is encephalopathic. This is a classical case of HIE. The initial arterial blood gas shows severe metabolic acidosis. Therapeutic hypothermia is started, antibiotics and dextrose 10%, and the rate of fluids is 60. We mentioned that HIE is one of the conditions where you need to restrict total fluid intake. Usually the baby in this age, and if the baby is healthy, will take between 80 and 100. We're giving only 60. And then we give a 10 milliliter per kg normal saline bolus because the baby is shocking. Is limp and encephalopathic, and the capillary refill is 4. So they give a normal saline bolus dose. And then subsequent arterial blood gas findings show interval improvement. The baby started to show some interval improvement in the metabolic acidosis, but it did not recover. The newborn remains mechanically ventilated, FiO2 70%, and the pressure now is starting to drop. So you see, usually drop in blood pressure is late in shock and in dehydration. Laboratory results show pH was initially 6.84, after the normal saline bolus 7.15, still metabolic acidosis or acidosis. PaCO2 40, now 21 because of the metabolic acidosis. PaO2 67 and now 56, hypoxemic. Bicarb 7, now 8, metabolic acidosis. Basic excess minus 27, minus 22. Severe metabolic acidosis with increase in the lactate level. Oxygen index is 18, 15, and the hematocrit, I think, was appropriate. Of the following, the best next step in the management of this infant's metabolic acidosis is. So we need to know why this baby is still having metabolic acidosis. Baby is on the vent, is given sodium normal saline bolus, still having severe metabolic acidosis. So why? So what should we do to manage this baby? Administer another normal saline bolus, administer sodium bicarb, obtain an echo, start a vasopressin infusion. Vasopressin, antidiuretic hormone, I don't know why. Vasoconstriction, I don't know. So maybe to treat low blood pressure. So which is the correct answer? A, B, C, and D, and Y. C, 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 C. Yes, the correct answer. B, no, it's not B. It's not B, it's C. Why C? Why C? Those who chose C, why C? Why you selected C? Just a smart guess. Smart guess. Exclude PIN. What is PIN? PPHN. Mir. Okay, if this baby is having PPHN, why should this baby have metabolic acidosis and starting to have drop blood pressure? And why this baby is shocky? Yes, myocardial depression from hypoxia. A very good answer, Hala. Sarah, thank you very much. Yes, this is a very good answer. Number 9, a 19-day-old neonate born at 25 weeks receiving CPAP for RDS. For the past 6 days, the neonate has been tolerating enteral feeding of fortified maternal breast milk at 160 cc per kg 19 days. بقاله 6 أيام بياخد fortified maternal breast milk 160 cc per kg per day. Caloric density 128 kilocal per kg. Protein content 4.3, which is very appropriate. However, the unit has had persistent tachypnea and inconsistent weight gain. He's getting good amount of fluids, good amount of calories, good amount of protein, but not gaining weight adequately, and has persistent tachypnea and inconsistent weight gain. Why baby is breathing fast? Laboratory results are shown. Hematocrit 42, sodium 136, potassium 4.7, chloride 106, bicarb 14, BUN 9, creatinine 0.4, glucose 85, calcium. Calcium was appropriate. 11, urine sodium was 45 millimole per liter. Blood gas pH 7.25, PaCO2 235, bicarb 15, basic cis minus 11. So this baby is having what? What is the problem with this baby? What is the problem? Metabolic acidosis, yes, metabolic acidosis. And why this baby is having metabolic sorry, This is not why. This is the effect of the following. The most likely cause of this neonate's recent suboptimal weight gain is inadequate enteral protein in provision, 4.3, I think this is inadequate. Metabolic acidosis, negative sodium balance, sodium was not bad. Suboptimal enteral energy provision, that was giving good amount of calories. So the correct answer is, it's a very easy question. Yes, it's metabolic acidosis. Yes, definitely. Number 10, a 1-week-old infant born at 31 weeks, pregnancy complicated with polyhydramnios. Every and each keyword in the MCQ is important. And as I told you, the maternal history is important, family history is important, fetal history, neonatal history. So there was a history of polyhydramnios, started to be noticed at the 24 weeks. Infant is SGA, polyhydramnios. Since admission to the NICU, the urine output is 8.9. Is this normal, high, low, per kg per hour? What is the limit? Is this polyuria, oliguria, or normal? This is definitely, this is polyuria, because if it is above 5, it is polyuria. Laboratory data are shown. Sodium 135, borderline, normal low. Potassium 2.8, definitely low. Chloride 94, the magic number is 96, low. Bicarb 34, high. So baby is declaring him or herself. Urine nitrogen 8, creatinine 0.6, calcium is 9.8, magnesium, oh, not bad. Usually we worry about high magnesium if the mom was given magnesium. Phosphorus, I think, was appropriate. So borderline sodium, low potassium, low chloride, high bicarb, and urine, there was polyuria. Urine specific gravity is 1004. Protein negative. There is no proteinuria. Calcium creatinine ratio is appropriate. No, it's not appropriate. It is elevated. So there is hypercalciuria. So what is this? What is this disease affecting this baby? Butter? Is it butter? Is it butter or barter? Barter, not butter. Barter. Yes, it is Barter syndrome, correct. In Barter syndrome, you have a renal disorder, and the classical textbook case is this case. History of polyhydramnios, SGA, polyuria, electrolyte disturbances, hypo, metabolic alkalosis, and hypercalciuria. And what is the treatment? Never mind. Of the following, these infant symptoms are most likely caused by the impaired reabsorption of. احنا فرحنا قوي ان لقينا ان احنا عرفنا التشخيص، راح حاطط لك سؤال مجعلص ملوش حل يعني. ولو ما عرفتش اجابته مفيش مشكله. impaired reabsorption of، بغض النظر عن الشانلز المكلكعه دي. كالسيوم there is hypercalciuria. Chloride there is hypochloremia. Sodium there is hyponatremia. Water there was polyuria. So all are possible, but what is the real pathologic problem? And to make your life easy, it is C. Sodium via NKCC2 channels. Before we go to discuss cases, I will go back to question number 1, because I need to have some clarification. Yes, because maybe I took it for, I understood it for a reason, and you took it, maybe you were more right than myself. A 6-hour-old preterm, yes. The question was about a 6-hour-old preterm. What I thought is just a 24-weeker with 640 grams. So, of the following, the major consideration in the fluid electrolyte management of this infant at this age, you were right, insensible water loss. I'm sorry. But after the baby passes the 24 or 48 hours and goes into the diuresis and hyponatremia, hyperkalemia, so it is the kidney. So initially, you were right, 6 hours. I'm sorry, I will take it back. So it is the insensible water loss. But after the first day or 2 days of life, it is the kidney. So you were correct, and I was right, because I thought differently in the in this baby. You thought it's okay for 6 hours, and I was thinking of only 24 weeker. I'm sorry. So cases. Before we go to cases, we still have 30 more. We have 40 minutes. We might be able to do 1 or 2 cases, because I will not go into the details. I will just show you the fluid and electrolyte disturbances and what is the cause. And then when I send these cases to you, you will read the details. Before we go, any questions? Any questions? You go for the chat. If you need questions, comments, go for the, go for the QSA, not for the chat. Go for the QSA. Questions, comments? No. Case number 1. This is an infant with severe dehydration and weight loss. So this is the key for this baby. Severe dehydration, severe weight loss. How did the baby present it? This is a female, 37-weeker, a vaginal delivery, uncomplicated pregnancy. Birth weight is 2680. 2680. It's still in the normal range, but yeah, normal range. It's not STA or LG. She is discharged home. Baby went home, started breastfeeding, did well initially. On day 10, she gained. She was above birth weight, 4% above birth weight. So everything was doing well till age of 10 days. What happened? On day 12, mother noticed that baby started to breastfeed poorly, poor breastfeeding. Then she switched to formula. Intake was still poor, and then decreased urine output. This is a very alarming and warning sign. This is a red flag. One of the common questions that you should ask for any baby in the follow-up visit, after you check the feeds and other conditions, urine out. Urine out. And this is a red flag. On day 16, 4 days after she started to become sick, she became cachectic. He means like she is wasted. Severely dehydrated. But however, she's responsive. So she's still not encephalopathic, not lethargic. This is important, but severely dehydrated. And her weight was 1,760 grams. She lost about 900 grams, close to 1 kilogram. This is horrible in like 4 days. This is horrible. and she was less than decrease more than 1 kilogram. Yes, from the last 6 days. This is horrible. She was admitted to the NICU. They did newborn screening, and it seems that they didn't believe it, and they had to repeat it, and maybe they're still suspecting it. They think it's not as sensitive as expected because the findings did not take them anywhere. Newborn screening results from day one are normal. At this time, the baby looked normal. However, they did repeat it because of the symptoms. On day 10, showed an abnormality in the fatty acid oxidation, like MCAD, or there was problem with the fatty acid oxidation profile. But usually they don't present this way, with malonyl carnitine levels of 0.68, with the normal is 0.5. So the level of malonyl carnitine level was a little bit on the high side, or slightly elevated, but it is a screening test. When you have an abnormal screening test, you have to repeat the specific test. Patients' initial laboratory tests were notable for the following. Sodium 174. Oh, this is hypernatremia. It's horrible, hypernatremia. Potassium 7.2. Severe hyperkalemia. This baby could die because of levels close to 10 of potassium. Chloride 141. Even the chloride is high. Bicarb is only 7. Severe metabolic acidosis. Blood urea nitrogen 273. The kidney, there is renal shutdown now because of the dehydration. Creatinine 5.61. Yes, there is AKI, renal shutdown because of the severe dehydration. And the glucose was 1,266. Everything was on the high range and severely dehydrated and hypernatremia, hyperkalemia, hyperchloremia, metabolic acidosis, renal shutdown, and hyperglycemia. At this point, what are your thoughts? What are your thoughts? And what is the key point in all these issues that will take you directly to the diagnosis? What is your what is your thought? What do you think is what is wrong is happening with this baby? And what is the key word for this case? Who can see your message reading? I don't know what is that. Sodium? Sodium? You think the window, the approach for this case will be through hypernatremia? How? How can you think this hypernatremia? And there is, if you notice, there is a very contradictory labs. Usually with hyperglycemia, you have fictitious hyponatremia. We've talked about that. But in this case, hyperglycemia is associated with severe hypernatremia. Correction of dehydration. I don't know what you are talking about. انت بتتكلم عن ايه؟ هتكلم بالعربي عشان ما تزعلوش. ايه مفتاح الحالة دي؟ انا ما بسألش على العلاج، ما تقوليش علاج الديهيدريشن من فضلك يا دكتورة ابتسام. انا بسأل ايه مفتاح الحالة دي؟ واحد فكر كويس وقال بري رينال اي كي اي. طب ايه اللي عمل بري رينال اي كي اي؟ ايه اللي عمل رينال شت داون؟ سيبسيس؟ يا حبيبي سؤالي هو ايه مفتاح الحالة دي في الكلام اللي احنا قلناه؟ ايه الحاجة اللي في الحاجات اللي شفناها دي ممكن تخلينا نفكر في تشخيص؟ كلام واضح جدا. يعني ايه بور فيدنج؟ طب بور فيدنج وصلك لايه يعني؟ بور فيدنج وصلك لايه يا استاذ او يا استاذ صدام؟ يا استاذ صدام، بور فيدنج وصلك لايه؟ انبورن، لا حول ولا قوة الا بالله. يا حبيبي انا ما بسألش على تشخيص، انا بسألك على مفتاح الحالة دي فين. هل هو في الهايبرناتريميا، في الهايبركاليميا، في الهايبركلوريميا، في الميتابوليك اسيدوزيس، في الرينال شات داون، في الهايبرجلايسيميا؟ مفتاح الحالة دي فين؟ ليه البيبي ده؟ ايه اللي في مخك اللي يفسر لك حاجة وان ديزيز يعمل لك كل الحاجات دي بيزد اون مفتاح الحالة؟ اظن كلامي واضح. انت بتقول هايبر ناتريميك دي هيدريشن، طب ما جميل قوي. ازاي ده هيوصلك للتشخيص؟ ايه التشخيص اللي وصلت له عن طريق هايبر ناتريميك دي هيدريشن؟ كلام واضح اهو. احنا بنتكلم بالمنطق، احنا مش بنتكلم طب، احنا بنتكلم بالمنطق، منطق لوجيك، لوجيك. خلاص. يا سلام، يا سلام، اخيرا بدينا ايه؟ هايبر جلايسيميا. هايبر، يا سلام يا هلا ويا امان، برافو عليك. ازاي بقى الهايبر جلايسيميا ممكن توصلنا لديزيز واحد بس؟ ها؟ يفسر لنا كل اللي بيحصل للبيبي ده. طيب ده هياخدنا برضه فاتي اوكسيديشن تاني. فاتي اوكسيديشن هيعمل لك هايبوجلايسيميا مش هايبرجلايسيميا باي ذا واي. وات ار ذا كوزز اوف هايبرجلايسيميا؟ مش انت حضرتك قلتي المفتاح؟ يا سلام، نيونيتال دايابيتس. ده كلام معقول، نيونيتال دايابيتس. وبالتالي هنفكر في other causes of hyperglycemia. هو ده مفتاح الحالة دي. إذا أنت ما عرفتوش مش هتوصل لتشخيص. خلاص. Anion gap was 31. It's very high. This is not a normal anion gap acidosis. Ammonia level was 83, which will exclude like ammonia, urea cycle defects, and other metabolic disorders. So beta hydroxybutyrate، بيتا هيدروكسي 3.1. امتى البيتا هيدروكسي بيوتريك اسيد بيرتفع؟ برضه في الدايابيتس. سيرم اوزمولاليتي 433. What is the normal serum osmolality? What is the normal serum osmolality? Is this hyperosmolar or normal iso or hypoosmolar problem? What is the normal serum osmolality? Yes, you are very close. Yes, you are very close. ماشي. 300, around 300. ماشي. So this is extremely high. Platelets were low, 33%. Sorry, 33,000. C-peptide level was 1.1. What is the C-peptide level and what does it indicate? And why we check it? And what happens if it is normal? I mean, what is the normal level? 0.8 to 4 nanogram. This is the normal. So when it's normal, when it's high, when it's low, what does it mean? What does the C-peptide level mean? Where is the C-peptide produced? What organ in the body secretes C-peptide? The pancreas. Great. And it's related to the ability of the pancreas to secrete insulin. When you find C-peptide, there is insulin. If it is normal, so insulin secretion is normal. If it is absent, there is no insulin secretion. If it is low, the secretion of insulin is decreased. So this is also another important key point. So these are the causes of hyperglycemia, prematurity. And when you give TPN to the baby, they cannot deal with the glucose load that you give, and usually they go into hyperglycemia. This is a very common problem. And IUGR, inadequate insulin secretion, and increased insulin resistance, increased stress hormones, and stress hormones increase in many conditions like sepsis, like severe sickness, like many conditions, or physiologic stress like hypoxia, pain, whatever. So in this baby, the cause was inadequate, not absent, but inadequate insulin secretion. And this caused neonatal diabetes insipid, diabetes mellitus, which is a separate entity. If somebody asks you, is it type 1 or type 2, it is separate entity. And it is two types. This type, in this baby, which is the transient, it will resolve on its own within 6 months. And it might recur, by the way. And it might cause diabetes in juvenile age, but it is transient. And this baby had transient diabetes. The other type is the permanent type, and I will not go into more details. How did they treat this baby? Definitely, they did fluid resuscitation. They did fluid insulin infusion. This was the hallmark of the management of this case. And the hypernatremia, hyperkalemia, hyperchloremia, all was because of severe dehydration. And I will send all these to you again. So neonatal diabetes, it is either transient or persistent. Usually it appears in the first 6 months of life. It may resolve, it may recur, it may cause diabetes in the juvenile age. And of course, the treatment is insulin. And this baby did very well and went home on no fluids, on no drugs. The C-peptide level in this baby confirmed that the infant was able to produce a very small amount of insulin and that she did not have complete insulin deficiency. This is important in the prognosis. And I believe we still have time for another case. Okay. We'll do case 2 and then we'll stop at the end of this case. Also, we'll not go into the details because the details will take us years. But before we move to case 2, any questions, comments? No. Case 2, a preterm infant with RDS and electrolyte disturbance. This is the main problem with this baby. Presentation. A girl admitted to a NICU for prematurity and RDS. Mother had diabetes, gestational, preeclampsia, severe hypertension. Mom had severe issues that can affect the baby. And mom received 2 doses of betamethasone after, and baby was delivered at the age of 34 weeks and 1 day by vaginal delivery. Mom was a 49-year-old, gravida 4 para 2, had significant obstetric history, including miscarriage, 1 miscarriage, 1 stillbirth, 1 healthy child from another partner. And the father had 1 healthy child from a previous marriage. There is no consanguinity, but this miscarriage, stillbirth, in the mother history is concerning. And this baby was the product of in vitro fertilization and a donor egg and a father sperm. So there is a donor egg, so mother does not play any role in this. I don't know. So this is a donor egg, and I don't know why a donor egg, maybe because of this history, I have no clue. But the father's sperm was given. So this baby belongs more to the father, I mean biologically and genetically. Mom was just a surrogate mother. I know these words are very weird on your ears, but this is what happens here. Fetal ultrasonography at 34 weeks yielded normal results. Birth weight was 1790. Baby was on CPAP. They did an X-ray which showed RDS. Apgar scores 4 and 8, which is not bad. They did limited laboratory evaluation for sepsis. They started empirical antibiotic therapy. CBC and DEF was benign, blood culture negative. There was a port wine stain on the right flank. Sodium level, second day after birth, sodium level was 141. And then on day 7, there was hyponatremia, sodium 127. So we have hyponatremia. And then hyperkalemia. So hyponatremia, hyperkalemia. Creatinine was 0.96, slightly elevated. Blood urea nitrogen 33. So there might be some sort of dehydration, some sort of mild dehydration, hyponatremia, hyperkalemia. Repeat potassium level was 10. Oh, it's horrible. Calcium was also elevated. Phosphorus was is slightly elevated. Blood sugar levels stable. Blood pressure, and urine output within reference range. There was no polyuria or oliguria. Blood pressure was still stable, but as mentioned, it is the least to be affected when there is dehydration or shock. EKG shows signs of hyperkalemia, PR and QRS intervals with normal duration and a normal T-wave amplitude. I don't know what is this. This means that hyperkalemia did not affect the EKG. I don't know. This is confusing. They give nebulized albuterol for hyperkalemia and K-exilate. At this point, back again, we have a preterm baby with RDS on oxygen. We have this weird family history, which does not, I don't think is related to anything, because this baby belongs to the dad who had a previous healthy baby from a previous marriage. And we don't know what about the donor egg, the mom who donated the egg. I don't know what is her health status. We don't know. This is the birth weight at 34 weeks. Baby is on CPAP, RDS, and then ruled out sepsis, CBC and different culture, CBC benign, culture negative. Then initially sodium was high, but after that there was persistent hyponatremia, hyperkalemia, high creatinine, high blood urea nitrogen, meaning a mild degree of dehydration. In your opinion, what makes this combination? Give me one disease that can cause hyponatremia, hyperkalemia, and mild dehydration. If you answer this question, you know what is the diagnosis of this case. Congenital adrenal hyperplasia. برافو عليك. Yes. في حتة بقى في الفيزيكال اكزام انا شلتها وحطيتها متأخر شوية، والا كنت هتعرفوا التشخيص على طول، اللي هي prominent there was prominent clitoris and labia minora or labia majora, which refers to something wrong with the genitalia. Yes, there was a fused labia and vagina. This was found out later. So, in a congenital adrenal hyperplasia, which I'm not discussing now at all, and I have a discussion about ambiguous genitalia, and it will refer to the congenital adrenal hyperplasia in details. I will present to you at some point ambiguous genitalia, which is a very confusing, important, challenging topic. So usually control of sodium and potassium through aldosterone and mineralocorticoids and glucocorticoids, it is the opposite. They increase sodium and drop potassium. In congenital adrenal hyperplasia, there is deficiency of those steroids, so the sodium will drop and potassium will go up. And if this is a salt-losing type, the baby might have a crisis of, or what we call adrenal crisis, or hypovolemic crisis, where the baby becomes shocky and hypovolemic. I will stop at this point, and we still have 2 more cases to discuss. If we go into the details of every and each case, we are going to talk for good. I will stop at this point. We are 10 minutes, less than 2 hours, 1 hour and 50 minutes. Any questions? Any suggestions? Any comment? Now, I don't know to speak in English or to speak in Arabic. Give me your final, do like a survey between yourselves, and every one of you should give me an answer. And if the majority will need us to use the English language, I don't mind. If the majority wants us to use the Arabic language, I don't mind. Somebody's asking about the port wine stain. It's not related. It's just not related to the situation. It is not a key point. It's just something they found in the case. Arabic or English? I need to know. I have now, we had around 50 attendees today. I need 50 answers. Arabic or English, Arabic or English. Because those people who did not like the English language, I saw a very sad comment, a comment that made me sad. The doctor said, once I see it in English, I leave. I don't want any one of you to leave. And don't think if you leave, this is going to cause any harm to me. It's you who are going to lose. I'm sorry for that. You are losing a very opportunity for education, teaching, and training. And I need every and each one of you to have full benefit from our presentations. And I don't know why today attendees are much less than usual. Is this because the article is not good, is not challenging? You don't use fluid and electrolytes in your NICU? Sometimes I cannot understand the mentality of the residents in Egypt. And I think that they like just spoon feeding. They don't like any active participation. And when they are assigned for doing any homework, they do it just without, من غير نفس, من غير تعب. أي سفلقة، أي حاجة ترميها وخلاص. And I will not accept any article that does not fulfill the minimum criteria for education, because now we are responsible of teaching and educating and training other persons who might believe in what we discuss. So if it is not perfect or close to perfect, we are not going to present. And from now onwards, Dr. Ahmed, just let everybody know, don't ask me for any references, because I believe 100% the residents don't read it. Don't use it. It's a waste of time and a waste of time and money for myself. So depend on yourself. Get references the way you like. I know ان انتوا بتسرقوا المراجع بطريقة ما، بتاخدوها من على الانترنت. خلاص, you don't need me. You have access to up-to-date now, which is free. Good. You have access to e-medicine. جميل. You have access to new reviews, pediatrics in review, new plus, pediatrics. You don't need me. If you are assigned to prepare an article, depend on yourself, look for the references by yourself, prepare it on your way, and don't send it to me. Don't send it to me. But when you present, be ready that I will stop you for anything that is not appropriate, is not correct, is not adequate, and be ready for hundreds of questions that I will ask you. Otherwise, don't prepare any article. And I can keep going with articles presentation. I can keep going with MCQs, with index of suspicion, with visual diagnosis. And if you are interested, well and good. If not, it's up to you. And I hope you did. These lectures were fruitful. They are on the YouTube. You can refer to them. If you have any comment, ask me, send me your comment, questions. And thank you very much. And now we have to leave. Assalamu alaikum.